This second lecture deals with airway management equipment and preparation. Adequate oxygenation, ventilation, and prevention of aspiration are keys to successful airway management. For many clinicians, direct laryngoscopy is the standard of care. After you've done your airway assessment and management planning and decided that proceeding with direct laryngoscopy after induction is safe, ensure that you have the proper equipment available and the patient is properly positioned. Many times it's necessary to build ramps for our beach patients so that they are in the sniffing position. The goal is to line up the external auditory canal so that it is on the same horizontal plane as the sternal notch. We've all been taught that there should be no more than 3 attempts at a DL, and each time you do one, you should change something. This could be the head position, laryngeal manipulation such as the Burt maneuver, switching blades, or using a Seldinger technique. When using the Eschmann, you should feel the clicks as they pass across the tracheal rings. Leave your blade in as you pass the tube. It helps to keep the tongue and soft tissue out of the way. If you get stuck at the arytenoids, turn the tube in a counterclockwise rotation. The laryngeal mask airway is a supraglottic airway device that has been in use since 1988. Initially designed for the use in the operating room as a method of elective ventilation, the LMA has more recently come into use in the emergency setting as an important accessory device for the management of the difficult airway. It is designed to sit in the patient's hypopharynx and cover the supraglottic structures, thereby allowing for relative isolation of the trachea. Laryngeal mask airways come in several types. At UC, the iGel is popular for its ease of use. The LMA Unique is a disposable version, making it ideal for the emergency and pre-hospital settings. The Fast Track is an intubating LMA. Although most designs can serve this purpose, the Fast Track has special features that increase the rate of successful intubation and do not limit the size of the ET tube. These features include an insertion handle, a rigid shaft with anatomical curvature, and an epiglottic elevating bar designed to lift the epiglottic as the ET tube passes. The LMA Pro Seal has the addition of a channel for suctioning of gastric contents. It allows for 50% higher pressures without a leak. However, it does not permit blind intubation and is not currently used in emergency settings. The LMA Supreme, which is a newer design, is similar to the Pro Seal and has built-in bite block. Intubating through an intubating LMA, such as the Fast Track, produces higher success rates than intubating through the standard LMA when doing so blindly. When you add the aid of a fiber optic scope, both are very successful. This can sometimes be limited by secretions and blood in the airway that are often seen with traumatic attempts with the difficult intubation. The size of the tube that will fit down the LMA is limited when not using the Fast Track. With the LMA Classic or Unique, a 6.0 ET tube fits through a size 3 or 4, and a 7.0 ET tube will fit through a size 5 or 6. The steps for intubating through an LMA are as follows. Hold the LMA by the handle, insert the mask into the patient's mouth and push it back against the hard palate, as shown in the first picture. Slide the mask backwards, following the curve of the tube. Swing the LMA into place and inflate the cuff. You can ventilate through the LMA until you're ready to put the tube in. I feel that doing this and making slight adjustments to better the ventilation gives you more success when putting in the ET tube. Before you put the tube in, inspect the balloon and lubricate it well. An ET tube should be included with the Fast Track, but a standard ET tube can also be used. Pass it through the lumen of the LMA tube into the trachea until intubation is complete. Confirm the placement with end-tidal CO2 and breath sounds. A bougie or fiber optic scope may also be used to assist with intubation. Once the patient is intubated, the LMA can be removed by deflating the cuff and passing it over the tube using a stabilizer rod, as shown here in the third picture. Leaving the LMA in is debatable. It depends on how long the case is going to last and how much trouble you had getting the tube in the first place. The equipment is very different at every institution. Know what is available where you're going to practice. Choice of equipment should be tailored to the patient needs as well as provider comfort. By this point, you should feel very comfortable using the glide scope or the CMAC. We'll have several other devices at the workshop for you to practice using. In the next lecture, we'll discuss the steps for an awake fiber optic intubation. Here we'll discuss the equipment needed. The team that you have assembled is as important as the equipment you have gathered. This includes the anesthesia team, the staff in the room, the surgeons, and the NT team if necessary. At UC, we have the airway tower, the store scopes that can be attached to the CMAC, and this disposable ambu system. You should make yourself familiar with this equipment wherever you go, because there may not be a tech to set it up for you. And as in the case here sometimes, they are new and not properly trained, and it is either not set up correctly or it's incomplete. Check to make sure that the equipment is functioning properly and that you have suction available. The more you work with the scopes, the more comfortable you'll feel with them. Doing an awake fiber optic is not the best time to pick one up and learn how to use it for the first time. Practice makes perfect. Make sure your patient is mentally prepared. Sometimes showing them the equipment that you're going to use and explaining your plan, or even giving them a yank hour suction, gives them a feeling of security. There are many different drugs that can be used for an awake fiber optic intubation, and depending on the team you're working with, there are a lot of opinions about what works best. Drying agents like Robenol are necessary to decrease the secretions for better visualization and for better localization, because the secretions from the mechanical barrier between the mucosa and the local, and they can dilute or wash it away. I usually give 0.2 to 0.4 milligrams either IV or IM if necessary. And remember, it takes at least 15 minutes for it to start working. If you're going the nasal route, you'll need Afrin nasal spray. It's a vasoconstrictor used to decongest the nasal mucosa so that you have a widened space and reduced risk of bleeding during the manipulation. Topicalizing the airway is the key to successful fiber optic intubation. Most practitioners here at UC use the 4% lidocaine nib. When it's used as an adjunct with other things, I think it works fine, but it's not enough alone. My favorite local is the 5% lidocaine paste. If I'm doing a nasal intubation, I put it on the nasal airway and slowly advance it as the patient tolerates. If you're intubating orally, it can be placed on an oral airway or the ovo sapien airway to localize the base of the tongue. Again, advance it as the patient can tolerate. The next step to topicalizing the hypopharynx, larynx, and trachea. This can be done with a translaryngeal anesthesia. Use a 21 or 23 gauge needle, pass it midline through the cricothyroid membrane located immediately cephaliad to the cricoid cartilage. Check that you are in the larynx by aspirating air. 1.5 to 2 mL of 4% lidocaine is injected during inspiration so that the local can spread to the larynx and pharynx. Coughing helps to spread the anesthetic. There are contraindications to this technique, including coagulopathy, local pathology, and the inability to clearly identify the cricothyroid membrane due to poor landmark visualization, as seen with most of our patients who are obese. Selecting sedating agents is as controversial as how to localize. The goal is to be very judicious and keep the patient breathing. If you do a good job localizing, you won't need that much. I have seen people use different combinations of Versed, fentanyl, propofol, ketamine, Precedex, remifentanil, and scopolamine. Polypharmacy can be very dangerous. If you stick to one or two choices and avoid large boluses, you're usually okay with whichever drug you feel most comfortable with. Always have reversal agents available. The emergency surgical airway is the last step to the difficult airway algorithm when the patient cannot be intubated or ventilated and it is no longer possible to wake them up. At the University of Cincinnati, as well as many other institutions, the Melker Emergency Cricothyrotomy Catheter Set, made by Cook Medical, is available and gives the anesthesia team the tools to perform either surgical or Seldinger technique. Listed here is a link to the website that contains step-by-step instructions for both. We will review them in the next lecture as well as at the workshop with the mannequins.